So as Adele just sang so beautifully, hello. And welcome to our closing session for the 28th Annual Ed Forum. I'm Newton Guerin, IWMF President and CEO. Just a quick reminder to please be sure to complete any session evaluations that you haven't had a chance to take a look at yet, because your input is really critical to the planning process as we begin plans probably starting tomorrow for 2024. And don't forget that with the exception of the Friday afternoon networking sessions, everything that we've seen here over the last 3 days will be available on demand on the virtual conference platform. So please take advantage of that if there's things that you missed that you'd like to see. So now it is my special pleasure to introduce Dr. Tom Hoffman. Tom is the Vice Chair of Research for the IWMF, and he is here with us today to facilitate and moderate our always popular Ask the Doctor session. So with that, Tom, it's all yours.
Good morning, everybody. I'm going to say right now that Dr. Treon was right last night. Those lights are terrible. Well, it's really great to be here again face to face. We've really missed that for a long time, and to be with our friends again. We have heard some very excellent speakers this weekend giving us excellent thoughts and truths about our disease, and it's been a great Ed Forum, I think. I'm Tom Hoffman, and I will welcome you to the Ask the Doctor Forum. This is where we learn things that cannot be found easily anywhere else, not even in Google. Thank you for sending us your questions. I have 86 questions, okay. And normally in 90 minutes we get 30 of them done. So I'm shooting for 40, but we'll see what happens about that. We'll try and get as many as we can do. The ones that don't get their questions answered, if you'll call the IWMF office and they can send your questions to me, and I'll try and find you some answers. I would like to introduce the panel today. I'm not going to talk about their bios or CVs because everybody has these and the answers are in there. The first was Dr. Who is that over there? Dr. Matous. Dr. Matous is at the Colorado Blood Cancer Institute. Next to him is Dr. Desai. He was at the University College of London Hospital. Dr. Shayna Sarosiek is an assistant professor at Dana-Farber.
God bless you.
Did I do it right?
You did it right.
Oh, good. Okay. Yeah, I thought somebody was laughing. So anyway, then Dr. Buske is at Ulm Hospital in Germany, and is also the senior consult. I will be giving the questions to our doctors, and any member of the panel can start the discussion and give us the answers. However, there are some that are directed directly to them because they're the ones that wrote the manuscripts. So we're going to be sure they did them right, but not really. We do have one disclaimer for the attendees. The answers you hear today are not medical advice for you, and they are not giving you a consultation. Please remember that any questions that our doctors answer today are for educational purposes only and cannot be taken as medical advice. Medical advice can only be given to your physician or a second opinion doctor. This statement goes for all doctors this whole weekend. So I guess we are about ready to start. The first question is actually the number 2 question that we're asked about, and this one goes to Dr. Sarosiek. Your manuscript, do we have it? I guess I've got to get it on here.
Oh, that's a good one.
Your manuscript, dose reductions related to adverse effects in the patients with Waldenström macroglobulinemia treated with BTK inhibitor and ibrutinib shows that many people do well on the lower doses, especially women. A lot of patients on ibrutinib and other BTKIs have pesky side effects that aren't being addressed and are a quality of life issue. Could you tell us now how you treat these people? Do you start them at a lower dose, and why or why not?
Great question. So I think initially when starting patients on a BTK inhibitor, we tend to use a full dose up front. I think that's where we have the most data and where the trials were initially using full doses of ibrutinib or zanubrutinib. When patients have side effects related to the medication, like loose stool or rash or things like that, generally my first approach is to try supportive care measures. I don't jump easily to dose reduction because often increasing fiber or probiotics, something like that might help with the loose stool, or there are other supportive measures we can use to help with the side effects. So usually I will try that first. If our attempts at supportive care don't help and the side effects are really bothersome to patients, then at that point we can consider dose reduction. It's not an easy decision, I think, because although this paper, when we reviewed information from in the past, it showed that patients can still do well. You never want to just easily make that decision and reduce the dose, because we also know from this paper there are some people that their disease did progress when the dose was lower. Whether that was going to happen anyway, we don't know. But I think if supportive care measures don't help and the patient's quality of life is significantly affected, going down on the dose is a reasonable decision to make.
That's great. I do have some follow-ups, but any of the panel can chime in and answer these. Why not start, this is one we've already done before, which as you can see on the screen, you'll recognize it, that you don't start low doses, and that was discussed yesterday. The next question is, could people on a normal dose of BTKI lower their dose when they become asymptomatic and are having a great response? Anybody?
This is a frequent question from patients, and I always say don't mess with success. You're doing well on the dose, you're tolerating it, there's absolutely no reason to decrease it, and in the States it doesn't cost less to decrease it. You'd think that X number of milligrams would cost less than 0.5x number of milligrams for these medicines. That's not the case. So if patients are doing well, responding, and tolerating a certain dose, I don't ever mess with that. I don't know about the rest of you.
Right, I think we have also to state, what you already said. We have the solid data for full dose. So this is proven by independent prospective, that's important, data sets. And the dose reduction, I think I fully agree that this is the way we do in many other lymphomas, which have a similar characteristic to Waldenström. When we have indolent B-cell lymphomas, where the quality of life is so important because you cannot eradicate the disease, we always do it like this. But the dose reductions are retrospective data sets. So I think whenever possible, exactly as you said, we should go for the full dose. In particular, when you are tolerating it well, there's no reason to decrease.
And I think stopping it altogether is a no-no.
Yeah, I think this we have really to emphasize. Don't stop on your own. It's not a good idea.
Okay. The next question is, why won't someone do a phase 4 clinical trial for decreasing dosage? Do you think that's going to come up sometime? Or?
I'm not sure how the program is, but here in the US. But so for many drugs in Europe, there's actually the obligation for the companies to do post-approval observational studies. So in that sense, the companies are obliged to collect data also on dose reduction and side effects, but I don't know how it is here. So I guess that these data are collected, but it's correct, I don't know any systematic phase 4 trial for this. So it's collected by the companies based on the authorities, but, at least in Europe.
I mean, we have a real-world registry, so
True,
that's
yeah.
one of our priorities, is to look at how dosing and side effects, etc., change over time. So it's like a phase 4, but it's a real-world study rather than a formal phase 4. I think the setting up of any trial is highly complex, and it's not easy to just pull off, unfortunately.
And perhaps you should also mention Whimsical from, you know better, so it's a very nice program which is patient-driven. Right?
Yeah, so the Australian Whimsical study as well. I think many of you have probably signed up. It's when you yourselves can input your data, and that's then analyzed and presented at meetings. And I can tell you, the companies are very, very keen on knowing what's actually happening beyond the trials, because trials have their limitations, and what happens in real life is what directs us going forward.
Okay, very well. This is great answers. The next question, is it inevitable that ibrutinib will eventually stop working for everybody who takes it?
I don't think so. I don't think so. I mean, you guys have people 12 years, Shayna?
Yeah, I think we definitely have patients that were on the early trials
Yeah.
who are still on the drug. So I don't think that's a guarantee for sure for everyone, but I think sadly none of us wanted to answer because it does happen, I think,
Yeah.
in most patients, that there will be progression of disease. We can't ever in medicine say anything 100%
Yeah.
because we do have people long-term doing very well, but
Yeah.
I think a significant number of patients, most patients will progress.
When I'm asked that, I say probably, but I introduce some doubt. Yeah.
Great. Next question. When will every doctor start prescribing zanubrutinib or BTKIs, other BTKIs, instead of ibrutinib? Is that going on now?
Probably it depends a little bit on the country and the reimbursement policy. So in Germany, we have the privilege that whenever anything is approved by the EMA, it's paid the next day in the country. But there are many countries where there's a huge lag time between approval and reimbursement, like in the UK. And so we start to move much more now to Zanu instead of ibrutinib when we start a new treatment in a patient. We are not switching when ibrutinib works, but when we have a new patient, zanubrutinib becomes more and more dominant.
Shirley, what's going on in the UK?
Where do you want me to start?
Do I need to get Carl up here?
No, well, basically, we no longer can prescribe ibrutinib because it came off the list. But we can prescribe zanubrutinib, but not in the front line. So for those who are already on ibrutinib, as Christian says, we continue that as long as it's working for them and they tolerate it. But we do have the option to switch them to Zanu as long as they haven't progressed on ibrutinib, because then that's not allowed. But so it's very much whatever the rules and regulations, that kind of dictates things for us.
The other thing is that doctors in practice get accustomed to using certain medicines and feel comfortable managing side effects. And so when there are choices, some doctors just have biases toward medicines with which they're more familiar, and sometimes are slow to adopt newer medicines. Those are, I think, that can be applied probably to general hematologists, oncologists. So I definitely see that in my community.
I agree. And we have many patients who have been on ibrutinib for a very long time and are doing incredibly well, and we continue the same thing. So.
Sure. All right. Those are great answers. On the sidelight, ibrutinib last year has dropped 18% worldwide in use. Be interesting to see where that goes. All right, Dr. Dessau, what did you learn about quality of life in Waldenstrom from your recent manuscript, Systemic Literature Review of Quality of Life Questionnaires in Waldenstrom Macroglobulinemia - need a disease-specific tool? What are you doing now about quality of life going forward?
Yeah, so we have a keen interest in this because of the climate of long-term continuous therapy. I think that's how people manage day-to-day over a long period of time is really important. So as part of our registry, we have had a system where patients can enter their own data quarterly to standard quality of life measures, which are used in cancer treatments globally. They're validated tools. But we evaluated the results and found that they really were not that informative in WM. And that was the conclusion of our study, actually. What it showed is that things like the EORTC and there are a number of things that my colleagues here will recognize. They're quite cumbersome to fill. And B, if they don't capture what you really want, if you don't see meaningful change, then they're not really useful. So the way we're moving forward is a colleague of mine, actually, Dr. Kyriakou, is working with the European organization, the EORTC, which is an oncology organization in Europe, to develop a scale for WM specifically, which is going through the process of testing questions amongst patients and then doctors, and then a series of refinements will follow. And eventually, hopefully before too long, we will be able to have a WM-specific scale to test. And I think that's because WM has a number of symptoms associated with it, probably IgM, mediated, that set it aside from other lymphomas. And I think that's why we do need our own scale.
Great, thank you. Dr. Buske, you recently tested DRC, which is dexamethasone, rituximab, and cyclophosphamide, with BDRC, which is bortezomib, with the other three drugs, and said it was better than DRC. Are you now using BDRC in everybody now?
Yeah, so I think it's just perhaps for you also, this was a large randomized trial which was designed before ibrutinib emerged. So at the time point where we only had rituximab chemotherapy, and the idea was, to try to optimize a mild rituximab chemotherapy. And DRC is very mild. It's much milder than bendamustine rituximab. It's less effective than rituximab bendamustine, at least with regard to response and progression-free survival. But with regard to overall survival, there are no data, actually showing that DRC is compromising your overall survival. So in this trial, we added bortezomib to DRC. What we have now published is the first report after a quite short follow-up, we have to say. So, Waldenström is a very indolent disease, and it takes time, fortunately, until we see progression of disease. So the first data we have now is that when you add bortezomib, the time to response is faster and you get deeper responses, and it looks like, but we have to be very cautious, that also your time to progression is prolonged. So this is all quite good. And when you look at the proportion of deep responses with bortezomib DRC, it's more or less the same as with ibrutinib. So every third gets a deep remission, CR or VGPR. So these are really excellent data. So I would say it's still a flowing data set. So we will do, end of this year, we'll do another data cut with a substantially longer follow-up, and we will see how the data will develop. You always have to balance efficacy with toxicity. And what we see when we add bortezomib is that you have a tendency towards more infections, and you have patients who develop neuropathy. These were very few. So we had around 100 patients treated with DRC plus bortezomib, and 2 had more severe, grade 3 or higher neuropathy. Most of the patients had resolving their neuropathy, but each additional neuropathy is one too much. So this means, again, you have really to weigh, and we state this also in the manuscript, the better efficacy with a slightly, or for some individuals, also increased toxicity. So short response, no, we don't give it to everybody, but with this data now fully published, we see it as an additional tool when we have patients with a high tumor bulk, for some reasons not being able to go on ibrutinib or zanubrutinib, and who have no signs of neuropathy when you start treatment. So it's a subgroup of patients where it might be beneficial.
Great, great. Okay, Dr. Matous, you were part of the ASPEN study showing that zanubrutinib has a higher response than ibrutinib. Which drug are you putting your patients on now, and why?
I think I definitely have adopted more zanubrutinib usage in my practice since the ASPEN data were initially published and have been more mature, more maturely analyzed. And so I think that outside of a clinical research study, I think I'm using definitely more zanubrutinib these days based on the ASPEN trial.
Several patients complained that Calquence, acalabrutinib, causes severe dreams and headaches at night that they can't stand. Should they stop the drug, decrease the dose, or could they take all the drug in the morning instead of morning and night?
That's the UK, right? Acalabrutinib.
Something else we can be blamed for. There's definitely an incidence of headache and hypertension in the Acala setting. There are ways of getting around it. In our participation in the study, we didn't need to stop anyone for that. I think we had about 8 patients on it.
I think it's early too, isn't it? An early phenomenon, the headache?
And normally it becomes better, but of course there are patients who continue suffering from this, but it's the classical ways that you have it at the beginning, but that you adapt to it.
It's manageable. I mean, people talk about using Tylenol and caffeine and that sort of thing to help. So I think some practical measures are feasible.
But of course, when it's too, as for all the drugs, when the side effects continue and compromise your quality of life, it's super important. So you are the boss, actually, as patient, and you have to tell us. Then you have to switch, for sure. But we don't use it in Germany because it's not approved in Germany for Waldenström. We use it in chronic lymphocytic leukemia, but not in Waldenström.
Shayna, do you guys use it very much? I mean, ACAL, yeah.
No, I have just a couple of patients that were on it before, and if patients are doing well, I
Yeah.
don't switch, but generally I wouldn't prescribe that up front just because we have more data than
Yeah.
other drugs.
All right. Next question is from a patient who says, I take statins for my high cholesterol. Then I got Waldenström, and my cholesterol level crashed. Is that real, or is the Waldenström just altering the test result?
I'm going to speak in generalities and stick my neck out and guess because I don't have any data on this whatsoever. But I think in general, patients who have more advanced cancers tend to have lower lipid profiles. And that can happen certainly in the setting if people are symptomatic or losing weight or having symptoms from their disease, we see that. The opposite thing we see is if the cholesterol goes off the wall. And if that happens, then I worry about the amyloidosis complication if that happens. But I haven't dealt with this question very often.
I actually sometimes see the opposite, actually, where patients, their cholesterol is well controlled until we start therapy and their IgM comes down, and then they actually have a much higher cholesterol level at that point. So I've seen that quite a bit. So I do think that there's some effect in it, interference, maybe in the laboratory, or some effect from the disease. And I think it's true what you just heard in terms of the cholesterol as patients who might have amyloid, or patients who have amyloidosis, or patients even who have Waldenström's involving the kidney. If they're losing healthy protein in the urine, significant amounts, then the cholesterol actually can go very high in those patients. So there are certainly some effects from Waldenström's and or amyloidosis on the cholesterol levels.
Good. His follow-up question is, since it dropped, should I stop my statins since the cholesterol seems to be normal now?
I'd consult a real doctor for that question.
Am I in the wrong room for that? I understand. I don't know either.
Yeah.
Okay. Where are we going? A moderate number of patients develop very high levels of IgM after COVID or other vaccinations. It stays high for a long time. Can you explain why this is happening, and have you or anybody else performed an electrophoresis to see if this is our Waldenstrom IgM or is a second spike?
So not systematically. So but what we see is, so we can confirm that this is happening, and also not only IgM, but they get also sometimes lymph node swellings, and so we always say that normally it's transient, and it's what you want to achieve with your vaccination, that you get an immune reaction, which also probably affects some activity markers of your Waldenström's disease. So, so the few cases I had, this was really the monoclonal IgM and not a polyclonal IgM. But all the few cases I overlooked, they had it in a transient way, so it was not true progression. Of course, you can have two things. So when it continues to stay high or even increases, then you have really to look for progression. So true progression, but at the very instance, I would be relaxed and just watch it and see what happens.
I would say that I've noticed people with IgM-related conditions like cryoglobulin and maybe even cold agglutinin disease after COVID or in vaccines can seem to get a bit of a flare. And I assume it's an uptick on the whole inflammatory environment temporarily. Because let's not forget that WM is a very inflammatory scenario to have in the body all the time. And when you're on, say, a BTK or something, it's being suppressed. But a stimulus like a COVID will send off a lot of cytokines and get things moving. So I agree with Christian. I think one has to just sit tight and wait and observe.
It's not just COVID. I've seen this after influenza infection also.
Thank you. Dr. Matous, one of the conclusions in the INNOVATE trial is that the information confirmed the role of ibrutinib plus rituximab as a standard care for Waldenstrom. When should you use ibrutinib and rituximab together?
You want to see doctors argue at WM meetings, ask them that question, and the senior author for that paper is to the far left, of course. But I think that when these data came out, I think doctors recognized this is an option rather for treating patients, and the study was designed before when rituximab was still the dominant treatment used in Waldenstrom, certainly in our country. And so the study was ibrutinib plus rituximab versus rituximab alone, and the combination of ibrutinib plus rituximab was far superior, however you measured it, to rituximab alone. For example, it seemed to decrease the risk of IgM flare, for allergic reactions, other things, and responses overall were better, but there wasn't a lot of adopting of that combination in the country, certainly to use that combination here. So sometimes I'll use that if I put somebody on a BTK or ibrutinib, and maybe I'm not getting the optimal response that I'd like, and sometimes I'll come in and add rituximab later, particularly if they have nodal disease or neuropathy or other things where I might talk myself into rituximab. But it's an option, but I don't think it's, generally speaking, widely practiced, even though it's pretty effective and the data are kind of persuasive. So I don't know how it is in other countries or other institutions, and maybe we should ask the senior author of the paper.
So what I have to, I have to support it, of course. No, it's just, so we are using it, or we used it, because now we have an alternative, which is ibrutinib single agent. So we used it in CXCR4 mutated patients. So when we had chance to have the CXCR4 mutational status of the patient, at a time where we didn't have zanubrutinib, we actually added rituximab. And then there's some quite strange approval situation in Germany. So in the frontline treatment, you are only allowed to prescribe ibrutinib or zanubrutinib single agent to patients who are not fit enough for chemo, which is difficult. So, but you are allowed to prescribe ibrutinib plus rituximab to everybody. So this is really a strange European policy. So this was for us a possibility to offer to everybody ibrutinib. And then you can keep off or take away rituximab after the first shot, and then you stay with ibrutinib as single agent and you get it paid. Yeah, so it was a little bit strange. But for the CXCR4 mutated, we did it, but would now prefer zanubrutinib because it's easier to apply than a combination.
I'd just like to add that when you add agents together, there is a risk of toxicity, especially with immune suppression. So beyond studies, which are obviously quite small, when you when you give the targeted therapy, you're inhibiting B cells. When you squash CD20, you may produce prolonged B cell suppression. And I think, this can add up to opportunistic infections. So I personally, I can't do it anyway, but even if I could, I would be cautious.
I would say the same, particularly in the setting of the COVID pandemic, when we, had this data earlier in the pandemic, because rituximab puts patients at higher risks for COVID complications or more serious infections. So we were very cautious about adding that when we knew as a single agent the medication, ibrutinib worked well. So we didn't adopt that change.
One word of caution also is that in the study, there were 8 total doses of rituximab, and it's a very unusual WM-type schedule for rituximab that was in the study, which is not familiar to most hematologists, oncologists who might be tempted to keep the rituximab going longer or to use more of it, which can result in more immunosuppression or other side effects. And so a word of caution to not do too much rituximab if you do the combination.
Great, those are good answers. Okay, Dr. Sarosiek, there are many papers out now that state toward personalized treatment in Waldenstrom macroglobulinemia. Will you please explain how you are doing this now?
Yeah, I think I alluded to this in my last breakout session, so some people have heard this, and I think in general, luckily, we have a lot of different treatment options for patients in the U.S. We have the luxury of being able to choose first line what we can use, and so I really think it's about asking your patients about their priorities and their goals. And some patients have very strong feelings about not wanting to be on an oral therapy indefinitely. Some patients have had negative family or friend experiences with chemotherapy and feel very strongly about not doing that, or patients who have had a lot of chemotherapy in the past for other cancers. And so it's really about, I think, thinking about your individual patient and their goals. And also, I think the mutational status in patients' disease also helps us to make that decision if they have a MYD88 mutation or not, CXCR4 or not. So I think you can choose, should a patient be on chemoimmunotherapy, or are they a candidate for bortezomib-based therapy or BTKI inhibitors based on their goals and their disease.
That's super, thank you. Dr. Buske, what can you tell us about your phase 2 clinical trial, BRI, bendamustine, Rituxan, and ibrutinib?
So we don't do a trial with bendamustine. Probably you mean bortezomib, rituximab, ibrutinib. It's bortezomib. So so it's a single-arm phase 2 trial where we actually, again at the time point where Zanu was not available, where we actually took up the idea to further improve the innovate backbone and to add bortezomib on top, because there were data, preclinical and also from Steve in a smaller phase 2 trial, which demonstrated that proteasome inhibitors act very nicely also in CXCR4 mutated patients. And so this is one of the trials of the European Consortium, which is now fully recruited. So I cannot say too much so far with regards to the data. So it was well tolerated. We had the discussion with the potential toxicity, so we had no major issues. But this was a clear-cut COVID trial. So it really went into the peak of the early COVID pandemics. And what we see is that there were a few deaths, and more or less the vast majority of deaths were caused by COVID, which is very unfortunate. But I think it's the fate of many of our trials, which really by chance were recruiting fully in the early phase, in the quite dangerous phase of the pandemics, and so we have COVID-associated death in this study. But otherwise, it was well tolerated, and we will start to look at the data now more carefully.
Okay, thank you. Dr. Desai, I have a patient here who has a very low IgM, but their peripheral neuropathy is increasing. Would you still treat with Rituxan alone since it only works 40 to 60% of the time, or what would you use?
So it depends on, I always use the word depends because it does depend on what they may have had before, the nature of the neuropathy, the connections. So I would evaluate the patient quite thoroughly to see, the nature of it, the rate of change, and how that correlates to the IgM. If the IgM is stable and low and neuropathy is getting worse, then it gets quite difficult to link it to the disease because an IgM or disease-driven neuropathy usually does show a rising IgM. I would look for light chains because maybe it's not so secretory. Sometimes the disease doesn't secrete IgM as well over time, so light chains may have come through. And I would think of other things like amyloidosis, etc., which can be a little bit out of the box sometimes.
Great, thank you. The next, we're going to go to the number one question that was asked for, and it's immunity. What lab test will tell us if we are immunocompromised?
I don't think that there's a for sure answer for that. I think we have some clues, certainly, from the blood test. So if you look at a patient's total white blood cell count, and when you break that down, you can see, for example, if the neutrophils are low, that a patient, would be at higher risk for infection or bacterial infection specifically. I think also we, can look at immunoglobulin levels or antibody levels of the IgG or IgA. Which can tell us if patients are making those antibodies. Having said that, a lot of patients with Waldenstrom's have a low IgG and are doing very well without infectious complications. So I think we have some hints from the laboratory data that a patient can have some immunocompromise, but the degree of that and how it clinically affects the patient, I think it varies tremendously from one person to the other.
So
I think the history tells us.
Exactly.
Yeah, go ahead, Christian. Yeah.
Yeah, so the most important lab test is to ask the patient, did you have recurrent infections?
Yes.
Yeah.
That's it. Because it tells you everything, yeah, and there is no lab tests which can substitute this question, so the medical history, because it's influenced by so many factors which we cannot reflect by lab testing, at least at the moment.
I have patients with IgG levels of 150 who are in a family full of COVID and they never get COVID and don't get frequent infections. I have other patients with high IgG levels who get infected all the time, so it's much more complex than any lab test.
Okay, the next question, we got a few of these. Everybody states that people with Waldenstrom are immunocompromised by definition. What about Mugus? Are they immunocompromised?
I suppose theoretically some are, because some people with MGUS may have reduced other antibody levels. I don't think this usually translates into an actual increase in infection, to my knowledge. And I think it's a bit like the other question. I mean, the proof is in the pudding, as we say in the UK. It's what actually is happening to the patient that's most important. Theoretically, there may be a greater risk if someone has low antibodies in general, but I don't think it's necessarily a clinical problem.
The Icelanders are doing a pretty cool study where they asked a bunch of people over the age of 40 if they'd be okay getting blood drawn and having urine tests and looking for MGUS. And what they found was an astounding high level of MGUS in their population. So I always tell my patients with MGUS that if you go to a football game and there's 80,000 people in the stands, and you take all the people 50 or 60 or over and start looking for MGUS, you're going to find it in 5 or 6 or 7% of those patients. So MGUS is really, really common. So I don't think that immunocompromised state is a really significant problem with MGUS, or otherwise our hospitals would be fuller.
Yeah, what I also emphasize is that to my patients that they are not patients. It's a lab phenomenon. Yeah, it's like an aging marker, as we have many, many others. So when the patients are fit, healthy, and they are not patients, it's psychologically very important. It's a lab phenomenon which we control. And this is in line with the observation that I also don't have any experience that MGUS patients are suffering from heavy recurrent infections. As it's a lab phenomenon. You are not a patient.
Okay, thank you. I'm going to skip the next one and go to what level of COVID restrictions do you recommend now for patients with Waldenström?
Ask Dr. Brannigan. Yeah. So.
I understand. Okay, let's move on. What treatment drug would be best for protecting our immunity?
Hand washing. I'm serious. Yeah, hand washing, being smart, avoiding obviously sick contacts. And I mean, I always tell people it's common sense stuff. It's common sense stuff. Just practice common sense things. And everybody has a different tolerance for risk, for infection, right? Patients always do. And you know, we all get these questions from patients all the time, right? Hey, can I take this trip? Can I see my grandkids? Can I hug somebody? I'm going to a wedding. Do I need to wear a mask? I mean, we all get these questions. I think we individualize them and just find out what patients' tolerance for risk is. Yeah.
I think if you're so risk averse that it interferes with your just living and enjoying your life, then you're probably doing too much.
Wash your hands.
Very good. I'll skip the next one also. And if you were vaccinated and wear a mask, and this person said until an additional dose was approved by bivalent, but that's happened since that was in, are we still limited to large groups, bus trips, and group meals? I think we've answered that too, haven't we? Yeah. Okay, so let's just keep going.
Did Dr. Brannigan, I didn't go to his talk, did he mention the FDA's new guidance for updated vaccinations? Did he mention that?
Yeah.
Okay, yeah.
Yeah, and a lot of stuff out of IWMF also. Another member doesn't believe that bivalent booster covers the current viral strain anymore. Should we take it anyway?
We'll let Dr. Brannigan go home.
Okay. This is the end of immunity.
Yeah, the answer is yeah, we recommend it. There are different strains in different parts of the country, right? And I don't know how it is in the UK or in Germany, but there are different strains, and so I think it makes sense to get vaccinated when our regulatory authorities and our professional societies make the recommendation. Yeah.
Yeah. So we recommend really for vaccinations, and depending on the situation of the patient, we even do sometimes more.
All right, we're through with that. Okay, now we have a patient that's been treated for neuropathy, and the IgM has not dropped tremendously, but my PN is still the same 6 months after the treatment.
Yeah.
Why?
So Shirley, you are a neuropathologist here, but
So I think it depends on what treatment was used, because the depth of response can relate to the treatment administered. So rituximab alone can produce some lowering, but but complete responses are extremely uncommon. I mean, you may get a partial response, so if you're just going by IgM levels, then it depends on the treatment employed. So the more you add to rituximab, the deeper you're likely to get in terms of an IgM response. Now, whether that translates into clinical benefit is another matter. Conversely, if you use BTKIs, often you get what I call circumstantial evidence of improvement. So you get a great low IgM, high hemoglobin. But once again, it depends on what's happening in the tissues, and in this case, it's the nerves. And often, depending on the pathology of the nerve damage, there's quite a lot to unravel. And there is this lag between IgM responses and response in terms of clinical improvement. And sometimes there's just a stabilization of improvement. So it does come down to individual case assessments. What I would say is if someone has progressive neuropathy and things are going the wrong way, then that is a red flag. But for those in whom there's an inadequate response, one has to check how that correlates with the neuropathy. I don't know if anyone else has a...
I completely agree with what you were saying, and I often, patients will ask me sometimes, do I need to be following regularly with a neurologist as well? And this is my own personal opinion that as an oncologist, my neurologic exam and complete assessment of neuropathy is not going to be anywhere near light years. The neurologist is light years beyond me in terms of that. And I think that can sometimes be helpful if you're following with a neurologist too, to have an objective evaluation of the neuropathy, because the changes can be very slow. And from day to day when you're living with the neuropathy, I think it can be hard to notice if the changes are happening in a positive or negative way. So having someone that's very specialized, if it's your oncologist that can do it, great. If I'm your oncologist, don't count on my neurologic exam if I do it. But I think having someone that can objectively also measure what's happening with your neuropathy is also very important to see, has it changed? And maybe it's so gradual that you don't notice. And also, sometimes maybe your treatment was effective, but the nerves do not heal quickly. Mm-hmm. And that might be a little bit more tincture of time that you need in some cases too. I think it's very nuanced and requires...
Dr. Desai went to her session this morning on neuropathy to learn more. And one thing that I think is absolutely true is that the more long-standing the neuropathy, in my experience, the less likely it is to improve, even if you control the IgM. Sometimes the damage is done, and our goals of treatment aren't necessarily to improve the neuropathy, but to hopefully ward off deterioration of the neuropathy. That's what I tell my patients sometimes. Yeah.
Great. Next question is, if my Waldenstrom transforms to another lymphoma, like DLBCL, will I have Waldenstrom also at the same time?
Generally speaking, yes. Often the treatments for diffuse large B-cell lymphoma, I would say, all the treatments for diffuse large B-cell lymphoma will help with the Waldenstroms, and often it will get your Waldenstroms under better control when you receive that therapy. But we don't expect the treatment for the diffuse large B-cell to really be curative for your Waldenstroms. So.
Very good, very good. Next, what is the percentage of transformation to different tumor for BR versus BTKI?
No different.
I think we have no solid data to compare this. So first, the rate is very low. So I think you have not to be afraid that bendamustine or BTKI leads to a higher rate of transformation. So at the very early beginning, when we started to use ibrutinib, there was always a little bit of fear of clonal selection, but we don't see this. So I think the rate of transformation is not a fact which would guide our treatment choice in Waldenstrom. I think we also summarized this in the consensus reports, which will appear very soon from the last International Waldenstrom meeting in Madrid. We don't have the data. But to put it in the positive way, you don't have to be afraid that we give you in any way treatment strategies which would trigger a secondary transformation.
Thank you. Along with raised levels of IgM, I also have lower IgA pre-treatment. My oncologist explained this situation as the increasing IgM cells leave little room for the IgA cells in the bone marrow. But the Waldenstrom cells in my marrow is only 10%. What do you think the real reason is?
I would say in my practice, often I'm explaining to patients that, the malignancy is taking up space in their bone marrow and perhaps additional cells can't grow. But I think it's much more complex than that, and we don't talk about it so much, but there's a lot of research on the niche or the actual signaling and environment in the bone marrow itself. So sometimes even a small amount of the cancer cells, even if they don't take up all the space, they might be releasing factors into the bone marrow that suppress how the healthy cells are working and how they're being produced. So it's not necessarily just the number or the space exactly, but it's also what those cancer cells are doing and altering in that environment.
All right, very good. Next is Shingrix. Does Shingrix inoculated patients also need oral antiviral prophylaxis during treatments, some treatments?
That comes down to physician bias, I think, for sure. I think with certain drugs, we think the risk of shingles reactivation is higher, and examples would be bortezomib or Velcade, anything with dexamethasone in it. And so even at my personal thing, I always say, look, the viral prophylaxis with low doses of, for example, acyclovir is cheap, well tolerated, and it's better than shingles. And so even in my vaccinated patients, sometimes I frequently recommend with certain regimens, varicella zoster virus or shingles prevention, but not all patients. There aren't very many regimens in WM where I think we need to do that. So, yeah.
Good, thank you.
But Shingrix, everyone should get it. I mean, and a lot of patients have only had the old shingles vaccination. It's important that everyone is up to date with their Shingrix vaccination. Yeah.
Great, super. Why do some people have extramedullary disease?
Shirley?
So I think, again, it comes down to the microenvironment, the crosstalk between WM cells and their niche and different expression of different molecules. CXCR4, for example, the receptor is something that binds a chemokine, which is something that is dealing with homing of cells from, in other words, where they preferentially stay. And I dare say that in people with extramedullary disease, that is beyond the bone marrow, these homing mechanisms have been disrupted either by the way the disease has progressed or even influenced by treatments, because let's face it, our treatments really do turn the disease on its head in many ways. And so they end up turning up in different places, many tissues. I mean, virtually any tissue, actually, you can see WM cells. So I think it's more common now because of the therapies we use, and I think because we are disrupting the tumor cells in ways we don't fully understand. Obviously, it's with a view to treating, but it does mean that the biological behavior changes. So I think the pragmatic thing is to not take anything for granted, to assess new symptoms, such as, we've seen bone infiltration in about a dozen patients, which on biopsy is basically WM. It's not myeloma, it's not lytic disease, but it's painful. So I think it's drilling down on finding out what the symptoms are and looking at those areas. And also if there's a big change in a swelling, for example, then biopsying to make sure it's not transformed. But looking in detail at each case and then deciding how to manage it.
It's clearly in the biology. So it's quite a stable characteristic. So when you have a patient with lymphadenopathy and this patient gets a relapse, very likely he presents again with lymphadenopathy. So every Waldenström is individual in some way and has its pattern of spread and its biology. Of course, there are exceptions when you have a transformation or whatever, but it's, as Shirley said, it's depending on the homing profiling of the cells. You know, Waldenström can be very similar to marginal zone lymphoma. Some are very similar to chronic lymphocytic leukemia. So there are all these, it's not black and white, so it's a continuum between the different lymphoma entities depending on the biology. So not everybody has a classical Waldenstrom, which only sits in the bone marrow.
Great, thank you. The next question is, if you have only one large lymph node and it is Waldenstrom and it's impinging on a body organ, should you use radiation or drugs to shrink it?
It depends a little bit on the individual situation. So normally, Waldenstrom is a systemic disease. So even when you have a single lymph node, it's a systemic disease. So meaning that a local treatment does not fight against the rest of your body. But otherwise, I would not say absolutely no. We have the same discussion in follicular lymphoma a lot. So when you have a heavily pretreated patient or an elderly patient not tolerating so much systemic treatment, and this patient has a local problem, a local treatment is excellent, yeah, and you can use it. And we have data from follicular lymphoma that, for instance, low-dose irradiation in elderly patients not tolerating, again, systemic treatment or being heavily pretreated can be very beneficial. So I think it really depends on the patient's situation.
You can give 2 fractions usually with great effect, can't you? So 2 doses does the trick, and it may obviate the need for more systemic therapy until that's needed.
Agreed. We have, a few patients, a handful of patients that we have used radiation just localized when the rest of the disease is well controlled, or there's a reason why the patient couldn't get other systemic therapies, and it can be very effective. So not routinely done, but definitely some cases it's warranted.
I've heard some with bumps on their back, and where they just radiate them out and whatnot. All right, well, next we're going to go into a little issue and dig into hepcidin. Can you explain the role of hepcidin in Waldenstrom-related anemia?
I think it came out of the Dana-Farber.
It absolutely did. Yeah.
But I will say
Yeah.
that was
Before you,
before my time, so I'm gonna say that I think that I'm not an expert in this particularly. I think we do know that the malignant cells in Waldenstroms can contribute or can secrete hepcidin, and hepcidin is something that's known even outside of cancers, actually. We know patients who have inflammation in their body, ongoing inflammation from other medical issues, they have higher levels of hepcidin, and that essentially prevents the body from being able to use iron appropriately. And so there was a paper out of Dana-Farber years before I came that showed elevated levels of hepcidin, which, so in patients with Waldenstroms, they can have some difficulty being able to use iron appropriately. So some patients will benefit from oral iron supplementation, and some patients can benefit from IV iron, and sometimes that will allow them to kind of overcome this barrier that's put up by the hepcidin and allow them to be able to create more red blood cells.
I think practically the point is just if anemia is the driving factor for initiating therapy for a WM patient, it's important to evaluate other potential causes of anemia, and would the patient benefit just from having iron supplementation would be one thing. There's a rare phenomenon where patients' immune system can actually attack the red blood cells and make the red blood count low and cause anemia. And sometimes that can be treated in a very simple fashion rather than having to institute full-on WM treatment. So if anemia is the major driver for considering the initiation of therapy, it's important to consider easily fixable causes of the anemia.
And on the subject of iron, one of my neurology colleagues mentioned that if you have restless leg syndrome and you're iron deficient, that can sometimes improve with iron replacement. So worth thinking about.
Good. Once you look at the iron levels and to send a patient to infusion iron, do you have a level that breaks it that you should do that? Or is it just an overall thing with anemia and everything else?
We tend to look at the saturation level, which is, if it's below 15% or 10%, We tend to use that. Other things like ferritin are really difficult to analyze because it's a marker of inflammation, and so it can be sky high, and you can get all kinds of mixed results. And if it's all really, really difficult, then I ask my red cell colleagues.
Yeah, but, just to confirm. So iron itself is not a good parameter. We are not measuring iron, but the saturation proportion.
It's interesting that if you go to the clinicaltrial.gov, there are, I think, 331 trials on hepcidin, but it's, old ones and new ones and everything else. Pretty interesting. But what about anti-hepcidin monoclonal antibodies? Are they available yet? Heparin's one of them, interestingly.
I plead ignorance on that one.
Me too.
Yeah.
I don't know.
Let's see. I've already answered that. Okay, moving on. I completed 4 rounds of bendamustine, 6 rounds of rituximab in 2022, had a great response. My IgA and IgG are drifting. IgG at 176, IgA 12. My doctor suggested to take IVIG. He wants my IG between 300 to 400, but I haven't had any infections.
Don't have it.
That goes in the same direction what we discussed before. So we wouldn't give it.
Agreed.
Agree. I tell my patients you have to earn it.
Yeah.
That's the language I use, really, which is if you're low on your gamma globulin levels, then to start IVIG in this setting, you have to demonstrate that you have the need because of repetitive infections.
And I think it's because, mirth aside, I mean, IVIG does have potential side effects. It can affect the kidneys, and it can increase viscosity temporarily, but actually there's also a global shortage.
Yeah.
So it should not be used unless it's necessary.
All right, good. Do you have, you may have already mentioned part of this, but what are the criteria for initiating IVIG therapy in Waldenstrom patients?
Infections,
Same.
clinically.
Okay, good. My fat pad amyloid test is positive. Could this amyloid be from something in the past besides Waldenstrom? The amyloid diagnostic process does not quantify how much or how little amyloid has been deposited. So how do you know when to start treatment?
Good question. So I think it gets, amyloid can be a little bit complicated. I think the key thing with the diagnosis with amyloidosis in patients who have Waldenstrom's, first and foremost, is making sure that this is a type of amyloidosis that's related to your Waldenstrom's directly. So there are different types of amyloidosis, particularly AL amyloid is what's related to Waldenstrom's. Some patients with Waldenstrom's might have a different type of amyloid that's unrelated, and so in those cases you shouldn't be treating the Waldenstrom's to help with the amyloid. So making sure you know what type of amyloid you have is important. And then I think the most important thing that we think about is just assessing all of the organs. So amyloid can affect your nerves, can affect your heart, your kidneys, your lungs. So making sure that we have a good idea of if any of your organs are being affected. So many of my patients with amyloidosis can have some kidney dysfunction or nerve dysfunction that's related to their amyloidosis, and in those cases they certainly need treatment. We do have occasional patients, though, who have localized amyloid, so amyloid just in one location, or amyloid that's not affecting any of their vital organs, and in those cases we actually can watch. So for example, we have patients that might have a breast biopsy that shows amyloid, but then when we examine the rest of their body and watch closely their other organs, there's no sign that it's affecting anything else, so in those cases treatment might not be needed.
Great. That's good. Good talk. With the new therapies in place and in clinical trials that have less severe adverse effects, do you see anything yourself medicating with IgM Mugus or smoldering Waldenstrom in the near future? What criteria will you use? And be sure and think of quality of life.
Get Irene.
So we have.
Yeah, exactly. We need Irene. Go, girl. Go ahead.
Yeah, so when you have asymptomatic Waldenström or you have MGUS, you don't treat. So the best treatment is no treatment. So, and we have no data so far showing that you change the overall fate of the patients when you start to treat asymptomatic smoldering Waldenström or MGUS. So the best drug is no drug. So even when we have now new drugs with less side effects, they have side effects, and we have already discussed also the downsides of these treatments. So at the moment, no rationale to do this.
I agree. Currently, there are no data to treat in these circumstances. Having said that, I think it's certainly an area that needs to continue to be explored in the future to see, is there a way that we can come up with therapies that can, for example, if we had a curative therapy, would this be a situation where, we would want to use it so that patients don't ultimately develop complications or symptoms of their disease. We don't have that now, but an area of continued research to hopefully develop things that we can use in that setting.
There's still some confusion with bendamustine Rituxan about how many courses they have had. I thought that they should take 6 unless they are doing very well at 4, and then you can quit, because the 5 and 6 was told to us that it didn't do anything, it just increased side effects. So what do you say about how many courses someone should have?
Do we have any German physicians on the panel?
So, so we say 4. So I think it's also internationally consensus. So the clinical trials of Matous Rummel, who's undoubtedly German, were all done with 6 cycles. So this comes from the follicular lymphoma field. But we know that, for instance, in marginal zone lymphoma or Waldenström, toxicity seems to be higher. The patients are more fragile than follicular lymphoma patients. So there is no randomized comparison between 4 to 6. But it's, as I said before, it's a balance between toxicity and efficacy. And bendamustine is quite a hard stuff. So we would really, emphasize to go to 4. So in the clinical trials, and in a clinical trial there's already a bias to fit patients. So in the clinical trials, you lose 1/3 of patients on the way to 6 cycles. So in the study from Matous Rummel, he lost 30% of patients who didn't make it to get 6 cycles. And here you see already that even under controlled conditions of a prospective trial with this bias for fit patients, many patients don't tolerate it. So it's quite toxic.
So they curtail the cycles, yes? When you say they didn't make it, they
didn't
get to
make it,
6.
so the study was designed that, only when you had 6 cycles, you were randomized between rituximab maintenance and observation.
Yes.
But they survived.
Yes,
Okay. Yeah. Okay.
So this is my bad English. So they didn't make 6 cycles. So not that toxic. Not that toxic.
So I always tell patients if they're fit, we're gonna plan on 6. But when I get to 4, if the patient even looks at me funny, I know we're done. And if they're doing great and still responding, I'll give the 5th and 6th cycles without any question myself. But I always aim to get 4 in. And I also, the other thing that gets discussed is the actual dose, because the dose of bendamustine, it can also vary. And so the normal dose that we use is 90 milligrams per square meter, which is how big and tall you are. And so sometimes in frail patients, I think some of us go to 70 in very frail patients. But I usually try to give 90 for 4 to 6 cycles.
Actually, in the US, they started with 120 mg initially, so really tough, No, 70 is a good idea also.
Okay. If you stop at 4 because they have a great return, could you please define by a number of what great define means?
It's a clinical decision,
I think it depends on the goal of the treatment. So if you have a frailer patient who you want to get feeling better and have a good hemoglobin and have a response that's durable enough, then I think 4 is and a good response. That is enough for that patient. If someone is very robust and is doing really well on the treatment, and you're having a steady fall in the IgM and things are going right, then as Jeff says, we would say, look, just if you go for the 6, then perhaps you'll get a longer progression-free interval before you need further treatment. So again, this is where it's tailoring to the patient.
The other classic bendamustine response is that when you finish treatment and follow these patients for several months after they've completed the treatment, sometimes even out a year or beyond, the IgM continues to fall. And so I think we've all seen that in our practice as well. So, yeah.
So the classical patient in our hands is quite often patients with a high tumor mass, large lymph nodes, and in these patients, when it goes fine, then 6 cycles is great.
Good. Hyperviscosity. In a recent retrospective study on 825 newly diagnosed Waldenstrom patients, a serum IgM of greater 6,000 at diagnosis was associated with a median time to symptomatic hyperviscosity of 3 months. These findings may support the use of serum IgM level greater than 6,000 as a criterion for therapy initiation. At what IgM level will you treat asymptomatic patients with a high IgM?
Boston.
This is Boston down before my
your
time.
yeah.
I would say even the providers who were involved with this study, we don't have an exact number that I feel like you need to treat with the IgM. Certainly there's higher risk of hyperviscosity as you get to these higher numbers. And maybe it's a little bit like what we heard a second ago when I have a patient that's at 6,000 and they look at me funny. My threshold for starting treatment is lower at that range. If I have a patient with an IgM of 1,000 and they've had a bloody nose once or twice, I don't really think that it's related to their disease, but at 6,000 they have a bloody nose, and then my alarms are going off in my head that this could be the time to treat. So there's not an exact number. It's really based on the patient's symptoms, but we do, I think, get wary when the numbers are higher like that.
How do you guys handle this question when you have your patients that you're following for smoldering disease with high IgMs, and you're measuring the serum viscosity and it always comes back high? And so how do you handle the high laboratory serum viscosity and,
Honestly,
and
we don't check
hyperviscosity syndrome?
viscosity.
Yeah, that's my error then, yeah.
We don't follow viscosity routinely because we don't find that it's helpful. We found a lot of variability in that, and it doesn't necessarily correlate with the patient. So really, I try to counsel my patients when they get higher like that I tell them exactly what they need to be watching out for, and I want to know about it.
I've
right
got a
away.
chap whose IgM is 50. That's in our money, as it were. Is it 5? I don't know if that's 5,000.
5,000
And he's got a high viscosity, but I've been watching him for 5 years, and when I first met him, I quizzed him for half an hour, like, do you have this or that or the other symptom? And he didn't. And I quiz him every time he comes, and I say to myself, well, why would I start treatment now as opposed to next week? So I've watched him, and he's actually been fine. Every time I get a new fellow, they have a bit of a fit when they first see him because the numbers look really scary, but he's actually all right. So it is really down to how the patient is.
About 10 years ago, on the talk list, we had maybe 8 or 9 people who had over 10,000 who were asymptomatic, and they weren't getting treated or anything. Mm-hmm. However, one of them got a blind eye, and another one stroked and died. So it's just a terrible thing. You just got to watch them close. All right, CAR T. CAR T seems to have great results, but has some very, very bad side effects, especially neurotoxicity. What is the risk-benefit ratio, and who should receive it?
So we need Leah. So do you have experience with CAR Ts? So we have experience with CAR Ts, but not for Waldenstrom. So there will be a trial in Europe starting now. We will participate in the second half of the year, but it might be that in the US you are more advanced. I don't know.
No, we have a trial, but we've not enrolled anybody on it. I think it would be a very rare patient who would receive CAR T-cell therapy for WM, And those patients absolutely would need to be treated. They have to be treated on a clinical trial. So, and CAR T is difficult treatment. And there's a thought out there, hey, you're just giving somebody some immune cells back that work magically, but CAR T is a challenging treatment I would say in all patients.
And I think it's still got to declare its hand, more so in this disease group where people have more indolent disease. So there's a lot of optimization to be done. I think the CNS side effects have been improved by various treatments in other settings. So I think things are a lot better than they were 5 or even 3 years ago. But it's not something I would recommend unless there were really no other options and the patient was kind of well enough.
But there are patients with WM who pose enormous clinical problems that have very challenging disease where we would think about autologous transplantation or allogeneic transplantation at some point, and who have very challenging disease where I think CAR T cell will be in that discussion.
Exactly. I agree.
Great. There is an article that states 1.75% of Waldenstromers have bone lesions. They say in that article that they are lytic. Others say that lytic lesions are only in multiple myeloma. Are Waldenstrom lesions lytic or solid or both?
Well, we published our experience on bone infiltration by WM, and they were not lytic, but on MRI they were very infiltrative, and this was sometimes in the foot or the tibia, the femur, distal areas, humerus, back. So they were not lytic at all in our group, but they were painful. That's why we went looking for them, and we biopsied them because we worried about high-grade transformation, and many of them actually had pretty avid findings on the PET scan. So I think if there is lytic change in a WM patient, I would want to seek out or exclude IgM myeloma, which is a disease that's kind of on the same spectrum and basically behaves more like myeloma than LPL. So I think there is a gray zone, but in my experience anyway, the bone lesions are not lytic but can be painful.
Yeah, so the MYD88 mutational status could help in such a situation because myeloma is MYD88 non-mutated. So it's very rare. I have just seen very few cases, and they all came up finally as myeloma and were treated like this.
Thank you. With treatment and the lowering of IgM levels in Waldenstrom patients, is it possible to see the IgA and G levels rise again to normal levels after treatment?
I've seen that.
It's possible.
Doesn't always happen though.
Yep.
Possible, but I tell my patients that it doesn't always happen.
Okay. Next, how do you pick between BR and BTKI for treatment?
I think you review the great debate from yesterday morning video. Yeah, so, yeah. It's individualized. You sit down with your patient who needs treatment, and you lay out the treatment options and the pros and cons of all the treatment options, and your patient will invariably tell you what they want. At least in the States, that's the choice that we have, yeah.
Let's see. Does anyone on the panel prescribe subcutaneous Rituxan during their treatment? Of course, the first dose would have to be infused to be sure that you don't have a reaction.
Yeah, we do it on a regular basis.
Are you using that?
Mm-hmm. Certainly. First dose is IV, and then sometimes insurance actually dictates whether or not we can do that, but definitely it's an option after the first dose if patients tolerate it well.
That's great. That'll help a lot of people that don't have veins. Could you tell me why I now have 2 paraprotein spikes, IgA and IgM kappas, after 2 years on ibrutinib?
I think it comes down to the manipulation of the immune system as a sort of bystander effect. Personally, I think. I mean, we all produce. This whole discussion about MGUS. I think just because you may be having WM and on ibrutinib, it doesn't mean you can't be one of these people who has MGUS of another flavor. So I think that may be one explanation, or the fact that you may have a little bit of selection of other clonal conditions, diseases on a small level. So I think it's a moving target. Things change all the time with the immune system.
Thank you. Oh, this is getting pretty deep here. Researchers in UK conducted a clinical trial of PD-1 inhibitor Keytruda combined with Rituxan for relapsed refractory Waldenstrom patients. The trial was closed early in part of lack of precipitation due to COVID. Are any of you looking at using Keytruda or a PD-1 inhibitor for Waldenstrom and other clinical trials?
Not in Waldenstrom, but we have an ongoing trial exactly with this combination in marginal zone lymphoma. We are coordinating, and it works fine. So was there toxicity, or was it really slow recruitment, which actually...
Yeah, so it banged into COVID. We were obviously concerned about the kind of toxicities that one talks about with inflammatory reactions and so on, but we literally saw none of that. So that was reassuring. And 1 or 2 patients have done extremely well, but COVID unfortunately led that trial to close early, and there was no appetite to continue funding it.
Thank you. Well, we are running out of questions. What does biclonal gammopathy mean, and how does it affect me?
Sorry,
Can you repeat that, please, Dr. Hoffman?
can you repeat it?
Repeat it? Okay. What does biclonal gammopathy mean, and how does it affect me?
It just refers to the fact that, so clones of cells are normally these things called B cells that are normally in our bone marrow, and sometimes when they're replicating themselves, if there's an error, normally our body's spell check can take care of those errors and eliminate those clones, but sometimes the spell check doesn't work very well and these clones can arise. And so these clones can arise independently. So you can have people who have their IgM clone and can have a different clone like IgG or IgA. And in a related disease called multiple myeloma, we see all the time patients who have very deep remissions who are followed who have other little clones of cells which arise. And it's just a dysregulated immune system a little bit. And again, once I identify a biclonal disease, I follow both clones to make sure nothing's going on. But I can't remember the last time the second clone was problematic. I don't know.
Yeah, so I think you don't have it's not paralleled by an inferior outcome, or it's not a prognostic marker in that sense that it's a more dangerous disease. So you have to, it's like this as it is, and you follow and you treat automatically both clones. Probably one is the major driver clone, and one might be even just a bystander clone.
And I've had patients before that their report from their labs says that they have 2 IgM clones, but that is actually sometimes just IgM can circulate on its own in that Y-shaped antibody form it has, and sometimes it forms 5 of those together. And so sometimes that will look like 2 different clones, but often it's just one clone, whether the IgM is circulating as a singular entity or as a clump together. A pentamer is the word we use.
Super. If I take a treatment and it fails over time, can I reuse it? Should I switch to something else? Or what do I do?
Good question. It depends, I think, on which treatment it was, the reason for stopping, and how long you responded to it. So sometimes, if a patient had an excellent response and it lasted 5 years, 10 years, then maybe you could reuse the same therapy. If previously that therapy was stopped because you progressed or had toxicity, maybe not a good option, but if you responded well and have a very long period of time. Sometimes we do like to switch, especially if the time between therapies is not long, though, to approach the disease from a different angle and potentially get a long response again. But it's not out of the question. We don't always do it, but certainly something to discuss.
All right. That sounds great. We are down to where we are going to give the last question. And it's about pleural effusions. I had pleural effusions before diagnosis and subsequently on the left side only, bunch of thoracentesis and pleurodesis. Why does fluid collect? Why only on the left side? Is there a risk now of one on the right side?
I think the causes of pleural effusions include, other than lymphoma, can include inflammatory or infection problems. So it depends a little bit whether there was a concurrent infection. If there were lymphoma cells, then it could be the fact that lymph gland enlargement in the center of the chest has led to sort of overflow of lymph fluid into the pleural cavity. Sometimes there's the WM can infiltrate the lining of the lung, the pleura, the so-called extramedullary thing that we talked about before. I don't think it necessarily means it'll happen on the right. I think I would say, in my experience, most patients probably had some sort of infective trigger for a pleural effusion, perhaps even a previous pneumonia that wasn't even known about. But there may be a tendency to slightly extramedullary-like disease. But the treatment response should still be as good with whatever treatment has been taken, I think.
I do always think about amyloid, though, when I see patients with pleural effusions, because that can be a cause. So when patients have that, I work up for amyloidosis also.
All right, well, I think that we are through with the questions. We really went through that a lot faster than I thought. That's over 60. So I really appreciate the panel being here, and I hope that the audience does also.